These are the conflicts of interest I should disclose. So is chloride a problem? I think that Kenis has already answered to that. Probably no. But I think that when we are dealing with chloride content and chloride concentration in the plasma and balanced solution, I think it's better, first of all, to clarify the definitions of balanced solutions in terms of content of chlorides. And then I will discuss also the possible side effects of hyperchloremia in our body. Also discussing at the very end the, I would say, few clinical evidence we have on the possible effects and clinical relevance of this topic. So, first of all, I was curious to realize that the first time in which the term balanced solution has been employed was in 1933. This is an original article published on Science, actually, regarding the use of specific solutions for cultures of plant cells. And the two authors basically defined, defined a balanced solution as a solution which, under the influence of absorption or excretion of substances by the plant, tend to maintain a constant hydrogen ion concentration. So from the very beginning, the concept of balanced solution has been linked to a minimal effect on acid-base equilibrium. And we all know that when we infuse specific type of fluids, such as normal saline, we may end up to have a huge variation in acid-base equilibrium. This is just one of the several clinical trials supporting this hypothesis. This is 24 women randomized to receive either normal saline or ringer lactate for volume replacement. Actually, they received more than 4 liters, so a very large amount of fluid. And those receiving normal saline developed hyperchloremic metabolic acidosis. Here we have an increase in chloride content as associated with a decrease in base excess. So after these observations, in the market there were available different type of so-called balanced solution with two different aims. First of all, to highlight solutions able to minimize the effects on acid-base equilibrium, but at the same time, based upon also some evidences suggesting the hypothesis of a renal effect of hyperchloremia. With this term, we started to highlight also solution with a very low content of chloride. Now, at the moment, we have available 3 different categories of balanced solutions. And here we are talking about just crystalloids. We have ringer lactate or ringer acetate, which is hypotonics. This is true, with a concentration of sodium of 130, and a relatively normal concentration of chloride, with a strong ion difference of about 28. Then we have plasmalite with a more normal concentration of sodium and a very low content of chloride, ending up to have a strong ion difference of about 50. And this is why plasmalite is an alkalizing solution, as I will show you later on. And then we have stereofundinizer, which is probably less frequently used in our clinical practice. It has a concentration of sodium a little bit more higher, 145, and a same strong ion difference or ringer lactate, but at the price of a higher content of chloride, 127. So, does this content of chloride has some problems in our physiology? And what are the effects of hyperchloremia in our physiology? I think that we have 2 main and major effects. The first one, of course, is related to acid-base equilibrium and acid-base variation. And here, it's just important to remember that according to the Stewart approach, the variation of strong ion difference is related and is responsible for the variation of pH. An increase in strong ion difference leads to alkalosis, and a decrease in strong ion difference leads to acidosis. Now, when we think about the possible effects of IV solutions on acid-base equilibrium, of course, the entire picture is quite complex because we have 2 simultaneous effects. The first one is related to the variation of plasma concentration of electrolytes, and the second one is related to the dilutional effect, which has two opposite effects on on specific parameters of the acid-base equilibrium. At the very end, because we don't have time to go into details on this topic, but at the very end, the balance between these two phenomena indicates that the ideal balance solution, so that solution that has the capability of maintaining unmodified the acid-base equilibrium, is a solution with a strong ion difference equal to the baseline concentration of bicarbonate. So normally about 24 milliequivalent per liter in a healthy patient. So if you translate this concept to what we have in the market, we have stereofundin iso, which has a strong ion difference more equal to what we have in plasma in terms of bicarbonate concentration, with a minimal effect on acid-base equilibrium, but at the price of a higher concentration of chloride. Then we have, of course, Ringer lactate, which has the same minimal effect on acid-base equilibrium, but it's an hypotonic solution with all the problems related to that. And then we have plasmalite, which, of course, has a higher concentration of sodium, so it's not an hypotonic solution, and it has a very low content of chloride. It's the solution with the minimal content of chloride, but at the price of having a very strong ion difference, plasmalite is an alkalizing solution. So, what are also the other possible effects of chloremia in our physiology? And this relates to the possible effects of chloremia on renal function. This is actually the first article suggesting this hypothesis. In this in vitro study, the investigators showed that a higher concentration of chloride is able to induce a reduction in renal blood perfusion due to vasoconstriction of the renal arterial artery, afferent artery. And luckily, we have also some clinical data supporting this hypothesis. This is a very nice study, I guess, published a few years ago by the group of Di Leplobo, in which healthy volunteers were randomized to receive either normal saline or a balanced solution, in this case, plasmalite. And as you can see, patients receiving normal saline, of course, developed metabolic hyperchloremia and metabolic acidosis, but measuring renal perfusion with magnetic resonance, the investigators were able to observe in these patients receiving normal saline a reduction in mean renal artery flow velocity and in the reduction in the renal cortical tissue perfusion, suggesting the hypothesis that at least in specific portion of the kidney, the hyperchloremia may reduce renal perfusion. Now, do these mechanisms have any clinical relevance in the outcome of our patients? I would say that we don't have yet any answer, I guess, because we have many studies with some methodological limitation. This is one of the first one, published in 2012. We have already discussed this article, based upon a very large database of hospitalized patients, more than 32,000 patients. And in this clinical trial, the investigators compared the effects of the use of normal saline to the use of balanced solutions. And as you can see, patients receiving normal saline were those with a higher incidence of complications, such as the use of buffer solution, blood transfusion, occurrence of lactic acidosis, and also the use of dialysis. Then we have another study, which was the first prospective trial, although it was still limited because it was a before and after study, so it was not a randomized trial, supporting the same hypothesis. The investigators compared two different strategies, a low chloride content strategy and a standard chloride content strategy. And the investigator observed a lower incidence of AKI in patients receiving low chloride content solutions, suggesting and supporting the same hypothesis. But if we look at the literature, until a couple of years ago, there were, as I said, several trials, all limited, observational trial, retrospective trial, until the conclusion of the first randomized control trial, the split trial, that for the first time randomized patients to the two different strategies of IV solutions, normal saline versus plasmalite. And they enrolled more than 2,000 patients, and as you may know, these were the results. No difference in terms of renal outcomes. But, and I think I'm not the only person to think so, this trial has several limitations. So first of all, the inclusion criteria. In this study, the investigators included all ICU patients receiving crystalloid fluid therapy as clinically indicated, a very heterogeneous population. The study population was actually was including healthy patients with a very low incidence of comorbidities, low Apache 2 score, and less than 5% of patients with sepsis, so almost healthy patients. As a consequence, patients were exposed to a very low content of study fluid, just 2 liters over 90 days. And as a matter of fact, this was a feasibility trial, so there was no sample size estimate for the trial, and last but not least, there were no data regarding chloride concentration. So the hypothesis was that 2 different types of chloremia would have affected the renal function, but no data on chloride concentration of the plasma has been reported. So I think that this trial still leaves an open question on the possible side effect of hyperchloremia in patients at risk of AKI. There was another trial just published this year, the SALT trial. It was still a feasibility trial, so still limited. Probably included more severe patients, almost 1,000 patients, randomized to the 2 same strategies. And for the first time, this trial showed also a kind of dose effect. So the difference between the incidence of renal impairment in patients receiving saline as compared to those receiving balance, of course, is dependent also on the amount of fluids received. This is kind of obvious, but it was the first trial showing some data supporting this hypothesis. But I think that in 1 year, more or less, we will have probably more answer, because there is a large randomized control trial ongoing on this topic, the usual Australian and New Zealand trial, including 8,800 patients. But I suspect that we will not have any conclusive answer because, of course, the inclusion criteria are very heterogeneous. So at the very end, in my conclusion, I would like to summarize what we really know about the effects of chloremia and what we don't know yet. So we know that hyperchloremia may modify regional renal perfusion. We have experimental and also clinical study supporting this hypothesis. We know that high chloride content IV solutions may affect splanchnic perfusion, may have pro-inflammatory effects, leading also to nitric oxide production. But at this moment, we know also that a solution with 154 milliequivalent per liter of chloride content, normal saline, is worse than a solution with less than 110 of chloride content. But we don't know yet many things. We don't know yet whether the problem is hyperchloremia per se or acidosis. It's really difficult to tease out these 2 phenomena in a clinical setting and in experimental trial. We don't know yet whether we have a threshold of safety or injury below which or above which we have some safety or some detrimental effects. We don't know yet the real mechanism by which chloremia may affect renal perfusion. And I think that the evidence we have in our hands so far in terms of clinical settings are still of low grade. Thank you very much for your attention.